Hi, everyone. We will get started in about 1 minute. Thank you.
And do we need to tell staff when to advance the slides? Or is Cheryl advancing the slides?
I'm running the slides.
Okay.
Okay, we'll go ahead and get started. Good afternoon, everyone, and happy National Public Health Week. My name is Gerline Roberts, and I will be facilitating our session today. Really quickly, I just want to make sure we are recording. Okay, great. All right, on behalf of Sacramento County Public Health, I want to thank you for your dedication to this field and for attending our first of 3 Zoom presentations this week. A few housekeeping items before I hand it over to our wonderful speakers are that all participants are automatically placed on mute until the Q&A session of the webinar. If you have a question, please type it into the chat and our chat moderator, Melissa Ricks, will either answer your question in the chat or save it for the Q&A portion with the speakers at the end. Also, we have 2 American Sign Language interpreters with us, Cheryl Gallen and Carol Buck. Thank you both for helping us increase accessibility of this content. Now, for our presentation today, our speakers will be discussing how public health and accessibility are closely intersected. They'll be talking about how the county's Disability and Advisory Commission and Resources for Independent Living worked with Sacramento County's COVID-19 response to put this mission in action, what we can learn from this partnership, and other ways to weave public health and accessibility. To cover this important information, we have 2 wonderful speakers with us, April Dawson and Cheryl Bennett. April's last name was listed incorrectly on the flyer, so we apologize for that error. April Dawson is the Executive Director of Resources for Independent Living, also known as RIL, which is a peer-driven advocacy and resource center for people with disabilities and older adults in Sacramento counties and Yolo County. April conducts many trainings a year on how to include people with disabilities in programs and services. Next, we have Cheryl Bennett, who has worked for over 21 years in the office of the ADA coordinator for Sacramento County. She facilitates 3 to 4 public meetings per month for the county's Disability Advisory Commission, which is an active group of volunteer disability rights advocates appointed by the Board of Supervisors. Cheryl also provides training and technical support to county employees and the public on meeting ADA requirements and interacting respectfully with people with disabilities. April and Cheryl, thank you so much for spending your afternoon with us. I'll hand it over to you.
Thank you so much for having us, Gerline. And I'm going to get started with talking about our learning objectives today. So today we're going to teach you about disability in our culture, language, identity, perceptions, and stereotypes. And we're going to talk about how to identify discrimination and access barriers, both environmental and attitudinal barriers. And we're going to go over some tips and tools for effective communication and respectful interaction, and how to plan ahead with your community resources. Next slide, please. So I think it's important to talk about, who are people with disabilities? And, the short answer is that people with disabilities are all of us, right? Every single person either has a disability or probably will have a disability as they age. And people with disabilities make up there's people with disabilities in every racial, ethnic, gender identity, culture. People with disabilities are everyone. We're not just like a mono subset off to the side. And so just a few, quick facts. There are 61 million US adults living with a disability, which is 26% of all US adults. That's according to the CDC infographic that you can find on the Department of Labor's website. And quite a few people over 65 have a disability. It's estimated over 40% of people over 65 have some kind of disability, even if they may not think of themselves as having a disability. And one of the things that I try to change in society is I'm really passionate about increasing employment opportunities for people with disabilities. And that's something that's a really key part of RAL's mission. And unfortunately, despite the fact that, laws like the Americans with Disabilities Act have been around for over 30 years, we still have a huge disparity between the labor participation rate, which is just a fancy way of saying, people who are participating in work for non-disabled versus disabled people. And so 33% of people with disabilities are participating in some kind of a job opportunity versus almost 76% of non-disabled people. So it's really important to work to change that and to see people with disabilities as workers and people who can contribute to society. And a lot of that is attitudinal barriers that prevent that from happening. Next slide, please. So let's talk a little bit about intersectionality. I think that one of the things that I like to drive home when I make these types of presentations is like I said in the beginning, people with disabilities are all of us. Like, for example, my intersectionality is I'm a white woman, Scottish and Irish. I'm a wheelchair user. I'm relatively privileged. I live in Midtown, and I'm a cisgender woman, and I'm straight. And so those are some of my intersections. There's probably several others. I like to say that I love banana bread, and if a Hallmark movie was a person. So that's another one of my intersections, right? So let's talk a little bit about some of the diversity within the disability community, because it's such a rich culture. So 1 in 4 women have a disability, and it's estimated that 2 out of 5 non-Hispanic American Alaskan Natives have a disability, and that African Americans are more likely to have disabilities than other races and identities. And so disability is present across all ages, ethnicities, and cultures, and anyone may join the disability community at any time. Next slide, please. So think about, you might want to, usually when we have sort of a smaller group, I always like to ask people to sort of shout out or write out or raise your hand in other settings about, the different types of disabilities, because there's so many. So just a few things I want to say is that you'll see, I'll read the slide, but, when I talk about, deaf culture, that is a capital D instead of a lowercase d. And it's really important to note that, because people with disabilities also think of themselves as part of a culture, and the deaf community has a very, very rich, important culture. And so they don't want it to be a lowercase d, they want it to be an uppercase D. So and I'm seeing some people in the chat are able to write, mental and physical. Thank you, Robin. So you can write that in the chat if you want, but there's blind and low vision as a disability. There's capital D, deaf, hard of hearing, physical mobility, which is what I experience, including fine motor, psychiatric, mental health, intellectual, cognitive, developmental, and learning. And it's also important to note that a lot of people who have disabilities that you can't see. And so that can make it more difficult. When I go into a restaurant, people can see my disability. And so it might be a little easier for me to explain what I need, and might be a little more clear. Oh, just move the chair so I can sit at the restaurant. But if someone has a hidden disability, sometimes they have to be a stronger self-advocate, and they have to convince people that they really need the help that they say that they do. And that can lead to a lot of discrimination and behaviors that prevent people from living their best life. And we don't want that. So we just have to make sure that we recognize that just because you can't see someone's disability doesn't mean it's not real, and that person isn't going through something that you may not be aware of. Next slide, please. So we can talk a little bit about specific disabilities. In the Americans with Disabilities Act, there aren't too many specific conditions that are actually listed, but there are some. And basically, the ADA defines disability as something that affects bodily functions or major life activities. And this can also include people who have tested positive or who have had COVID, including the long haulers. And so what we're seeing is, especially with like the long haulers, is that COVID has, created new disabilities that people are facing. And as people go back to work who have struggled with long haul COVID, or even who have COVID currently, employers such as myself are struggling with, how to accommodate, that new subset of workers into the working environment. And we'll talk a little bit about this later, but one of the exciting things that I find about the post-COVID recovery, whatever that means, I don't think we're in the post-COVID world yet, but we're getting there, is that this is an opportunity to, take a look at some of the things that people with disabilities have been saying for a long time about flexible work schedules and things like that, and make sure that that those things are recognized as good for everyone. We now know that we can be productive at home, and we're helping people that'll help people with disabilities and all workers. So I think that that's something to keep in mind as we track how COVID and long COVID are affecting the workplace and the trends we're seeing, and how we can use that as an opportunity to, make a stronger workforce out of that information. So like I said, there's episodic disabilities. So disabilities that, they may be stable for a while, like epilepsy. You may not have a seizure for a while, and then one day you have a seizure. So it's episodic. Addiction, it's important to note that the ADA specifies that you have to be in recovery and not currently addicted to drugs or alcohol to be covered under that law, as well as there's side effects of medication. So you may have a disability or a health condition that you're treating, and then the medication causes, maybe drowsiness or something. And then you have a different disability in that moment. And then, like I said, the COVID or long COVID. Next slide, please. And now I'm going to turn it over to Cheryl to talk about same versus equal.
Thanks, April. So we're talking a lot about social justice these days. What does that look like for people with disabilities? It's easy to fall in the trap of thinking, well, if I just treat everyone the same, then everything will be all right. But that actually oftentimes does not achieve true inclusion. In this graphic, we have 3 images of some children standing next to a fence and watching a soccer game, looking over the fence, watching a soccer game. In the first graphic, we have each child is standing on a wooden box so they can see over the fence. There's a tall child, and he can see over the fence by standing on the box. There's a middle-sized child, and she can see over the fence by standing on the box. There's a shorter child on the right, who, even though he's standing on a box, they can't see over the fence. So that's equality. Everyone's being treated the same, but they're not getting the same result. Not everyone is able to fully enjoy the game in that context. So the next image, we have the same 3 children, tall, medium-sized, and shorter. They're all looking over the fence, and the boxes have been rearranged. The tall child is no longer standing on the box, but he can still see over the fence. The middle child is still standing on one box, and they can see over the fence. And the short child is now standing on 2 boxes. And now the short child can see over the fence and enjoy the game. So I like that illustration because I think it illustrates how accommodations often work. A lot of people think, oh, accommodating people is difficult and expensive and complicated, and you got to buy a lot of stuff. More often than not, it's just rearranging some things that you already have, or maybe moving some things out of the way. So in the final image, we have a situation that is more just. We've got all 3 kids watching the game. They don't need to stand on anything because instead of a wooden fence, a wooden barrier that you can't see through, there's a chain link fence that everyone can see through. So by planning ahead and thinking about inclusion before we build, it's a lot easier to achieve justice, true inclusion. Environmental justice is something that we often don't think about in terms of social justice, but for people with disabilities, environmental justice means being able to get from one place to another independently without assistance. So we have a few images here of some things that assist with that. The first is the yellow tile that you often see on the corners of intersections, hopefully every intersection. If they're doing it right, these tiles are bright yellow. That color is known as federal yellow, and it was selected because it has the most visibility from a distance for people with low vision. So in this picture, we have a man who is using a cane, a blind person's cane, and standing next to the, they're called truncated domes, or accessible warning tiles, detectable warning tiles. If they're constructed properly, there is a hollow space underneath those tiles, and the tiles have a bunch of raised bumps on them. So the person traveling down the sidewalk with the cane is paying attention to the noise that the cane is making, striking on the sidewalk. When they reach the intersection and the cane hits the detectable warning tile, it makes a pop, it makes a different sound, like a drum. And then the blind person knows to stop and find the push button, if there is one, so that they can cross the street. If there isn't a signal, traffic signal at this intersection, they wait and rely on traffic noise, the noise of passing traffic, to determine when it's safe to step off the curb out into traffic. If you are a person with low vision, these bright colors assist you in navigating toward the intersection safely, so you can see where you're heading toward. Now, a lot of people don't like these. They find them a nuisance. They can be slippery when wet. They make your shopping cart da 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 when you come out of the store, right? A lot of people really object to them, but they're extremely important for people who are blind and visually impaired to be able to navigate safely and independently. The next image on the upper right is an accessible pedestrian signal. Now these come in several different styles, but the one depicted here actually can be programmed with an audible message. Quite often, you're probably more familiar with the ones that just go cuckoo, cuckoo, or peep, peep. Those are the older style. The one in the image can actually be programmed to say something like northwest corner of Howe and Fair Oaks. And then when it's time to go, it will say safe to cross Howe Avenue at Fair Oaks. The round button in the center is very large. It has an arrow, which can be felt. It's raised and can be felt with your fingers, indicates the direction that you want to cross the street. And they also vibrate. So if you can't hear the audible signal telling you to go, you can leave your fingers on the button and it will vibrate when it's time to go. So if you are both deaf and blind, you can still cross the street safely. In Sacramento County, as we replace the older models, we're replacing them with newer models such as this, or if we get a request from the public saying they need one in their neighborhood to safely cross the street because of their disability, those requests go to the top of the list. The bottom center, we have an image of an individual in a manual wheelchair coming up a ramp. The ramp looks fairly steep, and I say that because I'm seeing handrails, which are required if the slope is excessive, greater than 8% or 8% on the ramp. And if a slope is greater than 10%, it can actually flip a person with a wheelchair over backwards. So this ramp looks to me like an afterthought. You see these quite often in older buildings where they were built. In fact, Sacramento County is a good example. They were built with stairs, and ramps were added later as an afterthought. Very expensive, often very unattractive. And again, if you plan for inclusion, we won't have to have these things. Well, we still need ramps, obviously, but they just won't be so clumsy and unsightly, such as this one. So It's important that all of our public facilities be accessible in its path of travel. Starting with accessible parking, we must have accessible parking spots with a clear path from the street or the sidewalk or the public transit stop. An accessible route into and through the public areas. So this became a challenge last year when we, or a couple of years ago, when we suddenly had to pop up public health facilities to administer COVID tests and eventually COVID vaccines. And we worked with community partners who had facilities around the community that they made available for our use for this purpose by contracting with the county. The problem is that many of these facilities were not set up for full accessibility, primarily because many of the facilities that we used were churches. And churches are not beholden to the ADA the way other publicly used facilities are. So we ran into a lot of situations where the facilities we were using didn't have a proper path of travel. As we mentioned earlier, the Sacramento County has a Disability Advisory Commission made up of volunteer disability advocates with subject matter expertise who helped us walk through some of the data after we had gone through and surveyed all of the facilities and identified some access barriers that we couldn't remedy through normal channels. A lot of the access barriers we found we were able to mitigate with things like creating accessible parking spaces of the right dimension and on a clear path of travel by using orange cones and laying them out in the proper configuration, or noting changes in level which might become a trip hazard by putting an orange cone, and then instructing staff how to set all this up properly each day that they open the facility. And in this way, we remedied all of the access barriers. The Disability Advisory Commission helped us determine what was the best way to accommodate people with disabilities with regard to the access barriers that we couldn't mitigate. And most of the access barriers that we couldn't mitigate were actually taken care of by staff support. Staff would go out and do curbside service or otherwise bring the service to the person so that they didn't have to navigate the barriers. So that's not ideal, but it's certainly workable. And since this situation was, such an emergency with a high volume of service required in a very short time, that was the best way to get it done. And I really want to thank and commend all of our public health staff and community partners for being creative and gracious and thoughtful and in getting all of those things accomplished. Great job and great team effort. Also want to thank the Department of General Services, Jeffrey Lebenko, who is a subject matter expert and helped us do a proper assessment of all of the facilities. So with regard to public access, it's not the case when we're providing public services that we have to make every aspect of our facilities accessible. Almost every facility is going to have some barriers. What we must ensure is that we provide equal or equivalent access to all of our programs, services, and facilities. And often that is done through reasonable modification of our policies, practices, and procedures. I just gave an example of that a moment ago when I talked about creating access through just changing the way we conducted business, bringing curbside service and so forth. For these kinds of accommodations, we never ask a member of the public for proof of their disability. Sometimes it's obvious, like April said, sometimes it's not obvious. Nevertheless, we just provide whatever that person says they need to participate in the program. And now I'm going to turn it back over to April to discuss History of bias in medical decisions.
Thank you, Cheryl. So I think it's important to lay the groundwork for the future of public health and inclusion by talking about the past. And the past can be really uncomfortable. And also it's important to know that the past isn't necessarily past. A lot of the things that I'm going to share in this slide are things that may still be going on in some communities, or things that didn't happen that long ago, like less than 50 years ago, even in some cases. And so it's important to know that, the past is not past, and that we're living the consequences of the way that people with disabilities have been seen throughout history in the context of medical decision-making and medical culture. And that affects, whether we want to admit it or not, the way that public health is done today, even though we're doing the best we can to change the past and to create a better future for everyone with public health. So just a few things that have happened to people with disabilities. And I want to note that, back to the intersectionality slide, a lot of these things have had a higher impact disproportionately on people with disabilities of color and certain communities like Native Americans or Mexican Americans or other communities. And so it's important to note that that's also how intersectionality comes in. And I'll talk a little bit about how we see those legacies today. So in like I'm probably not going to get the decades all correct, but in the early 20th century, there was still a lot of talk about eugenics. And that's basically sort of like thinking that it's kind of almost like the survival of the fittest. It's kind of like people with disabilities were seen as defective. And so the idea was, to make a better society, we had to, rid the world of people with disabilities. So you saw that, in World War II, when not just Jewish people were killed, but people with disabilities of all ethnic groups were killed by Hitler and his crew in the concentration camps. And you also saw a lot of forced sterilization, like in America. Like I mentioned before, we used to sterilize people, particularly people of color, because we believed that, that the best way to make, the perfect human race was to, destroy all of the people of color and people with disabilities, and that they were considered defective and not as good as white people who didn't have disabilities. And so you saw a lot of people being, sterilized without their consent, or they would go in for a treatment and think they were getting something else, and they ended up getting sterilized. You also saw that, with the Tuskegee experiment, when a lot of Black men were given syphilis and they didn't know that was what they were signing up for, obviously. And so you see those legacies today, because when you look at the people that are being affected by COVID the most, it's still disproportionately people of color and people who are in rural communities, such as Native Americans, who don't have as great of access to vaccines, and also just Black people and Latinx people. You're seeing them die at higher rates. And a lot of that has to do with just the legacy of racism and ableism that has been a part of our culture in public health, unfortunately. You also see a lot of people who were institutionalized, particularly people in the intellectual and developmental disabilities communities. They were seen as less than, and a lot of times when babies were born with Down syndrome or shown to have, a lower IQ or things like that, their parents were just told to lock them away. And a lot of times, even though their parents loved them, they did what they were told because they didn't have the community support. So today you might be able to have your child in a special preschool program, or go to a day program, or a place where they can get supported employment services. But in the past, when they didn't have those things, a lot of parents were just told to just put their kids in an institution. I don't identify as someone with an intellectual or developmental disability, but my disability type does sometimes manifest that way. And when I was born, my father was pulled aside by the surgeon and told that I would be a vegetable and to just forget about me and have other healthy kids. And luckily he listened to the other doctor who said the opposite. And so here I am, not a vegetable. I like to eat vegetables, but I'm not a vegetable. And also, a lot of times what you'll see in things like organ donation, for example, is sometimes people with certain disabilities are refused examination or treatment. So a friend of mine is a really big organ donation proponent, but a lot of times people will discriminate against people with disabilities in receiving things like organs because they'll say that, well, their quality of life is less than, so why should we give them a chance at another life, right? If they have an accident or something and need an organ transplant. And sometimes, one of the things that we saw in Oregon, Disability Rights Oregon is actually working on a big case, because when COVID hit, right before the bad stuff happened, like right at the beginning of COVID, there was evidence in Oregon that the medical facilities actually started rationing care before it was necessary or deemed necessary. And what they did was they started to prioritize the lives that society valued more. So people with disabilities and older adults were actually denied care or given or told not to come into the emergency room or put off to the side. Some people, at least 2 people they know have died and their parents have sued the state because of those decisions. And so it's just really scary. And when you look at the history that I just laid out and what's playing out now, it's this subtext that people with disabilities have lives that are not worth living. And so when there's a massive health crisis like COVID, let's make sure in their minds, in that mindset, that people who are considered healthy or more worthy get the care, and the people that don't are sent off to the side. And so we need to make sure that stops happening, and that people with disabilities have every right to the same access to care as everyone else, and their lives are just as worthy and just as valuable, and they're just as productive in society as anyone else, and they deserve an opportunity to have the things that they need during an emergency. Next slide, please. So this kind of talks about the medical model. I'm going to talk to you about 2 concepts: the medical model of disability and the social model of disability. So the medical model of disability actually plays nicely into that subtext I talked about of people's with disabilities lives being considered, not as worth living as people without disabilities lives. And so it's the idea that people with disabilities are sick, broken, need curing or fixing. So the idea would be that, I have a disability and so there's something wrong with me, or that they need to be the ones that change or adapt to fit in. So some people might say, like, if I go to a job interview and it's up a flight of stairs, oh, well, she can't go get that job because it's up a flight of stairs. And I'll talk to you about what the social model would say to that in a minute. But there's also the idea that, you should just stay home, stay out of sight. There actually used to be laws on the books, and it was only in the last couple of years that some of those laws were actually struck down. In Chicago, for example, I know someone who was having pizza with his best friend, and this was in the 70s or 80s, and he was told to leave the restaurant because they said he was too ugly to be there. And so he got arrested, and they had a right to arrest him because of the ugly laws that were on the books. And it's really scary that it wasn't that long ago that we still had those. And I wouldn't be surprised if there may be someone on some books somewhere that they just haven't remembered or there, but it could still play up when someone is wanting to discriminate against you just for doing something simple like going and having pizza with a friend. And then the other thing that I see a lot in my work is a lot of family members and friends and professionals think they know what's best for you if you have a disability. So a lot of people without disabilities are like, well, this person has, Down syndrome, for example. How can they live in their own home and do their own life? I'm going to always have to, be there for them and follow them. And they're not the right people to make the decisions for themselves. Whereas we know now that if you have a team of people, but put that person at the center of their own decision making. They can make decisions for themselves. They just may need a little help and need a support team around them, but they're the ones directing that team in consultation with the people that love them. And sometimes they don't need the people that love them. Like, I love my mom, but I don't actually need her to be doing a lot of the things that she might think I need, but she doesn't. She'd be mad if I said that. But and then the other thing about the medical model is emphasis on the impairment and dependence. So the emphasis is on the disability. The disability is the issue. Next slide, please. Yay, let's talk about the social model of disability. I get excited about this one because this is the one that my whole work is based on. So independent living centers like Resources for Independent Living, which are resource centers for people with disabilities and older adults, we believe in the social model, which is that the physical environment is what creates the barriers to work, school, or typical daily activities. So when I mentioned that example about the stairs, like April has to go to a job interview, it's up a flight of stairs. The medical model would say it's April's problem. Why did she even apply for that job? The social model would say, well, if we built a ramp or if we accommodated her and had the interview at another office or downstairs, she could potentially compete for that job and get the job. And the idea is that the cure is not to cure the disability, it's to remove barriers in the built environment. Also, we want to talk about attitudinal barriers. So attitudinal barriers, I think, are the things that are the most insipid and the things that, are the hardest to prove. Obviously, I keep using the example of the staircase that you can't get up if you use a wheelchair, right? Because I'm just using my own personal experience. But what about if, like, you're a manager? Like, I'm a manager, right? And I'm lucky that this doesn't happen to me very often, but sometimes, I'll get this feeling that somebody will start talking slower to me at a meeting, or they'll just kind of give you this vibe, like, how did she get here? Or they'll talk over me. And that might also be the intersection of gender as well, kind of talking over you and discounting your opinion. That's one example of an attitudinal barrier. Or just thinking that you can't achieve what you want to achieve, that you're not as equal in the environment, and then that creates barriers. They may not go right out and say, we're not going to accept you into our program, we're not going to accept you into our school, or we're not going to hire you for that job. But you know that the reason why is because they hold the belief, and they're in a position of power to hold the belief that you're not as good as another candidate or another participant. And racism, thank you, Robin, absolutely. The intersection of gender and racism and sexism and ableism. So ableism is defined as a complex form of prejudice, which is just like sexism and racism, and just as common and fundamental. Next slide, please. So let's talk a little bit about inclusive and respectful language. I actually have a whole presentation on this, and so if you're interested, I'm happy to come to your office or organization and do a deeper dive around this, because there's actually a couple of other there's a whole other conversation about people first language versus identity first language and things like that. But for our purposes today, we highly recommend that you default to people first language. You always want to refer to people the way they want to be treated and referred to. And if you don't know what that is, we always tell you in these presentations to lead with people first language. But like I said, there's a whole movement of claiming disability and identity first language that's happening right now, particularly among self-advocates on the spectrum. And so I'm happy to share that when we have more time. But so, for example, people first language would be person who is blind, people who use wheelchairs. So putting the person first and the disability second. And remembering a person is not their disability. The R word, a quadriplegic, an epileptic. You don't just, refer to someone as their condition. There's also an emphasis on ability rather than limitations, and that disability is not a tragedy or challenge to overcome. You'll hear me say a lot, though, I'll say something like, well, I'm disabled. And that's because I'm claiming the word and I'm not afraid to use the word. And we're seeing a trend now where a lot of young people with disabilities who grew up with a lot more access and accommodations than a lot of our people with disabilities in the past did are not claiming disability as much. And when they get to the adult world, like college or the workplace where the onus is on them to claim their disability to receive services or accommodations, they don't have those skills. So it's really important that we teach people that it's okay to say they have a disability, and the D word is not a dirty word. All right, next slide, please. Okay. And it's important to know that people with disabilities, like I said, are just people. They're not their mobility devices. They're not their disabilities. They just happen to have disabilities. I tend to go a little bit further than that. And I claim that I have a disability, and it's just a part of who I am. And it's just something that that is a part of what makes me me. It's not the whole thing, but it's not something that I discount. Like I don't feel like I've overcome my disability. For example, I feel like my disability is always going to be with me. And it's just, I wouldn't be the person that I am if I didn't have it. So words matter. So please don't say wheelchair bound. Please don't say special needs, differently abled. I remember in 7th grade, physically challenged was like very nouveau. And I just went with it because I wanted to have friends, but it was gross. And then there's some people who don't even like people first language. So what I said before. So a lot of people, like in the autism self-advocacy movement, they say that I'm autistic, and they're proud of themselves. And they are contributing to a lot of scholarship in that area. So there's a lot of change going on in the disability community as far as how we want to be viewed, and we want to be the ones that define how we're viewed. We don't want to just take on what society thinks. The other story that I always like to tell is sometimes I'll be on the bus, and the driver will say, well, I need to get the wheelchair off the bus. And so what I do to counter that is I'll say, well, can I come too? Because a lot of people will think that, you know, they'll, and it's not intentional, but it's still nonetheless not a good customer service tactic, where they will kind of be thinking about how to offload everyone. So they'll be like, okay, got to get the wheelchair off. And they'll say it out loud, but then they'll dismiss me as the person who's sitting in it. And so that's why I always have kind of, and sometimes they'll get it and sometimes they'll look at me funny, but I'll be like, can I come too? Because it'd be weird if my wheelchair went without me off the bus. All right, and now I'm going to turn it to Cheryl, and she'll talk about effective communication.
Okay, thank you, April. That was an excellent summary of inclusive communication, which is critical and important. But the ADA also requires us as public entities to provide effective communication. And for many, receiving equivalent services means alternative modes of communication. So let's use the recent COVID service as an example. If a person who's blind comes in and gets a COVID shot, and you hand him or her an aftercare sheet on printed words on a piece of paper, and that person is blind, have you effectively communicated with that person? Likely not. It's very likely that a person with low vision is not going to be able to read a printed document. They may need it in larger print. They may need it in an audio format. They may need it read to them. Maybe they don't have a computer at home that can read the document in electronic format. So as a public entity, it's our responsibility to provide the additional support that people with hearing, vision, or speech disabilities may need. We have to provide the aids and services on their request, and we are required to give primary consideration to the aid or service of their choice. So for example, if the person says, I need an ASL interpreter, it's not acceptable for us to say, oh, we'll just exchange written notes. That person may not be very proficient at reading English, or maybe they can't write. We have to give primary consideration to the aid of service of their choice. They know what they need to communicate. They got this far, they know what they need. We do have some leeway with regard to the nature and complexity of the communication. If someone is just arriving at a public counter to make an appointment, and it's going to be a very brief transaction. Exchanging notes or communicating by reading lips may be okay in that scenario. For something more complicated, where the person might be needing to make decisions about their health or a legal matter, you want to make sure that they are getting the full body of information. And in that case, it wouldn't be appropriate just to exchange little notes. You would want to have an ASL interpreter or whatever support they requested. They have the right to have the information in a way that they can understand it. That's the critical element. So for people who are blind or have low vision, the types of aids and services that you may need to provide are qualified readers. Qualified meaning they have to have the skill set to manage the language that's being dealt with. So somebody may not be able to read complex medical language, for example. You want to make sure that you have a reader that is qualified to do that. Large print documents, audio recordings. Back in the day, I used to have to read a lot of printed material into a tape recorder and send off cassette tapes to my constituents who are totally blind. Nowadays, there are many computer programs which do that, and I don't have to do that anymore. Electronic files, MS Word, .txt, and if they are properly formatted, PDFs. And last but certainly not least, Braille is still used, although the Braille language is kind of a dying language. It's mainly used by older folks, and it's not being taught as much to people who are blind and visually impaired because it's being replaced by some of the technology we just described. The types of aids and services we may need to provide as accommodations for people who are deaf, have hearing loss, who are deaf blind, or have speech impairments. Again, qualified interpreters or note takers. Real-time captioning, also called CART. That's when a person sits next to the deaf or hard of hearing person and types all of the conversation that's going on in the room or in the meeting, so that the person can augment their hearing with the written words that are appearing on the screen. Nowadays, video relay service and video remote interpreting are more commonly used, and it's a great cost savings for the agency to not have to hire 1 or 2 interpreters. Often you have to hire 2 because of the nature of their work is extremely taxing on their joints, repetitive motion injuries if they interpret too long. So if your event is going to be more than an hour, you have to have 2 interpreters so they can switch off. Although video relay service and video remote interpreting, as convenient as it is still not preferred by many people who are deaf, and it's not always as effective as a personal interaction. Again, last but not least, we still have TTYs, TDDs, which are text telephones. Those that have those either talk to each other or talk to people in the hearing world using the relay service. If you dial 711, you will reach an operator who will assist you with communicating with the deaf individual. They will either be signing using video remote interpreting. They will be signing to the deaf person, and the deaf person will sign back, and the operator will speak back to you, the hearing caller. Or if they're using a text telephone, you will speak to the operator will type, the deaf individual will type back, and the operator will read the message to you. Now, obviously, that's a very cumbersome way to communicate. It takes a while, but it is effective. And the ADA specifically recognizes this with regard to inmates. Inmates who are deaf and rely on TTY or relay service to communicate with the outside, they are allowed 3 to 4 times the amount of time for phone communication compared with hearing callers, because it takes that amount of time to communicate the same information using that method. If you are working with someone who is deaf or hard of hearing, you want to be sure that you're facing that person directly when speaking. Keep hands or objects away from your mouth. That person may be relying on lip reading to augment their hearing. If you're working with somebody who's using an interpreter, talk directly and keep eye contact with the person, not the interpreter. You don't want to say things like to the interpreter, tell him or her, the deaf person, that blah, 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 blah. You want to talk directly to the person and keep eye contact with that person. I find that personally extremely challenging because all the activity is with the interpreters and your eye kind of wants to go to where the motion is, but it's very disrespectful to do that. You want to talk directly to the person and not pay attention to the interpreter. The interpreter there is just to facilitate and is not part of the conversation. Be aware of ambient noise in your environment. Some people can hear it just fine in a quiet room, but lose their ability to understand in a noisy room. And if you're working with someone who's deaf or hard of hearing, particularly if they're using hearing aids, speak in a normal tone of voice. Yelling doesn't help, and it might even hurt. If you are working with someone who has speech disabilities, just be patient and pay attention. Be aware that their communication is going to take a little longer than a typical person, and that's okay. Don't finish their sentences or presume to know what they're going to say. If you don't understand what they're saying, it's okay to ask them politely to repeat it back or paraphrase back to them what you heard for clarification. They know that they're hard to understand and they want to be understood, so they don't mind a respectful request for clarification. And be aware that many people with speech disabilities may be using various devices or techniques to enhance or augment their speech. If you're communicating with somebody who is blind or has low vision, state your name and introduce others who are present when greeting them. They may not be able to recognize your voice unless there's somebody that you've worked with for quite some time. Offer a sighted guide if you have to travel somewhere with them. That means just offering your elbow to them. They will put the back of their hand or put their hand on the back of your elbow or maybe lightly grip your elbow and then just walk as you normally would. They will follow your pace. If you are going through a narrow doorway, you would put your arm behind you and tell them that we need to walk single file and they will follow you through the doorway. Let them know about obstacles or barriers, in the path of travel, like we're about to go down a flight of 3 stairs. Never push or pull a person with blindness or low vision. Offer them your elbow and they will follow your movements. Describe your activities during interaction. They may not know what's going on, and it's helpful to let them know what you're doing. Let them know if you need to leave the room or end the conversation. Excuse me, April, I need to go down the hall and make some copies of these documents. I'll be right back. Okay, now I'm back. Here's your documents, April. Okay, so that's helpful to them so they're not just sitting there wondering what's going on. Be specific when describing location and surroundings. People with vision disabilities rely on lots and lots of descriptive words. If you're working with someone who has emotional, psychiatric, or cognitive disabilities, try to make the environment as distraction-free as possible. If you need to, you may want to move to a quieter location. Keep your communication calm, simple, and focused. And again, just be patient. You may need to allow extra time for this individual to complete tasks. If you are working with someone who has mobility disabilities, if you're a person in a wheelchair, put yourself at their eye level. That is such a gracious gesture. All of my friends who use wheelchairs always comment on this. It's so nice if somebody is thoughtful to come and sit down and talk to them at their eye level. They don't have to strain up to look, and the person who's standing isn't looking like they're towering over them and being intimidating. You never want to push, lean on, hold, or do anything with a person's wheelchair or mobility device. It is part of his or her personal space. It's almost like an extension of their body. So if you bump into their wheelchair, say, excuse me, just as if you had bumped into their person. Be aware that people with mobility disabilities may choose not to use any mobility devices, and that may cause them to move slowly. That's okay. We support that. It's their choice, their decision. And be aware when thinking about mobility disabilities that it's not just about wheelchairs. It can be things like reaching, lifting, grasping, opening doors, writing, manipulating a pencil, fine manipulation, keyboarding, those kinds of things. Those are all mobility disabilities that may require assistance or accommodation. No, I got messed up on my slides here. Oh, before we go, I just wanted to make a quick, say a few things about service animals. If someone arrives for services and they have an animal with them, you may wonder, is this really a service animal? You can usually tell by the behavior. Service animals are highly trained and always well behaved. In fact, most of the time you won't even know that they're present. If they are not well behaved, they are probably not a bona fide service animal. But what we recommend here in Sacramento County is that if they are an emotional support animal or even a pet, it may be the case for that individual that they're not going to be able to get through the appointment or the service without the support of their animal. So unless the animal is out of control, causing some kind of disruptive behavior, like barking or odor or being aggressive, that kind of thing, you can ask the client to remove the animal. Hopefully, maybe they've brought somebody with them that can take the animal outside while that person gets their services. But we want to make sure that all of our clients and patients get the services that they came for. So whether or not you think that the animal is a bona fide service animal, please do your best to manage the situation so that the person gets their services. You'll want to designate a relief area, an appropriate place where someone could take their animal out to be relieved. They should supply their own cleanup materials, but if they don't have them, it might behoove you to keep some on hand just in case. And with regard to animals in the workplace, we do have to consider other clients and our own employees who may have allergies or just generic fear of dogs. Those folks have to be accommodated too.
All right. Well, I know that we have a 2-minute warning, so I'm going to just talk to you about planning for access really quick. It's really important that you designate a responsible staff person to be your site ADA coordinator, and at least make sure that when you're posting information about programs and services and how to be sure that you're really clear about how a person can request an accommodation, and make sure that there is a specific person they can talk to throughout the whole process. I see that is the biggest miscommunication I see, is not clearly posting ADA notifications and not having a designated person. Also, think about compliance versus usability. Just because something follows the letter of the law doesn't mean that it's universally designed for everyone and that it's usable. So think about real people, use clients and ask them to test products and services. And then I think it's really important to just treat people with dignity and respect. Don't make assumptions. Be sensitive about physical contact. Remember that words matter, and that meeting functional needs is customer service. And so I know that we cut into our Q&A, and I apologize for that, but I just want to thank all of you for the important work you are doing to save lives and protect our community. And if we could put up the last slide, If you need additional information, you can always call myself or Cheryl's office. Like I said, I'm happy to come and do a presentation. And you could also talk to the ADA Center or respectability.org or the Job Accommodation Network as well. And you will receive a copy, I believe, of the slide deck. Someone is asking that. And I'm happy to do a deeper dive into any of these concepts with your teams. Thank you.
Thank you so much, April and Cheryl, and also to our ASL interpreters, Cheryl and Carol. And then Melissa, do we have any questions other than the slide deck?
We do not. That was the only question.
Okay. Awesome. Well, thank you all for attending, and we will get those slides out to you. Have a good afternoon.
Thank you.